There we go, the magic words, recording in progress. Hi, everybody, and I'm really happy to introduce my guest for this week's episode. It is Dr. Amanda Olson, and we're going to have a chat today about magic wands and dilators of all sorts of shapes and sizes. And I say that because I am particularly enamored with the shapes and sizes of Amanda's rectal dilators. So there is a certain logic to this train of thought. September, when we're recording this, is it's Pain Awareness Month and it's Gynae Cancer Awareness Month. And I think there are so many misconceptions that are out there about using uh, great tools like wands, particularly intimate rose wands, for helping people take care of their own pain and dysfunction. With pelvic pain diagnoses, but of course after gynae cancer as well, because we all know that radiation really is the gift that keeps on giving after a lot of the pelvic cancers. So Amanda, thank you so much for being here. Delighted to have you on for a chat. Would you just fill us in a little bit about, who you are, where you're from, your journey to today?
Oh, thank you so much for having me. It's such a pleasure. My background is as a pelvic health physio, pelvic health physical therapist. I've been at it for 14 or 15 years now. I'm starting to lose track. And additionally, I create wonderful products at Intimate Rose to help empower people to be able to manage really sensitive issues on their own. My journey to pelvic health began, I actually went and got my doctorate degree in physical therapy expressly to specialize in pediatrics.
Oh.
And I started my career in peds, and I had a horrific accident in my first year of practice. I was still a pretty young person, but I was in a scenario where I was out in nature with a big group of friends, and the boys, the men, were jumping off of a cliff at 40 feet. It was a cliff jumping space. I live here in Oregon in the United States. It's very beautiful. We have a lot of
Mhm.
rivers and oceans and mountains and things. And it's one of those where the river is very deep and very still at this point. People have been jumping for years. None of these are good reasons to do it. Um, but off the cliff I went, and at 40 feet, apparently you're supposed to land straight when you cliff jump. And I landed in an L, bottom first,
Ooh.
and annihilated myself. At 40 feet, water behaves like cement. And so I sustained significant injuries. I'm so lucky. If I'd rotated a little bit more, I could be gone. But I
Wow.
had to go see a pelvic health colleague for the significant damage I did to my pelvis and pelvic floor. And she helped me tremendously. She changed my life. And at the end of our treatment session together, she said, Amanda, you need to quit peds. You need to do pelvic health. You have the right personality for it, and there's a huge need.
Oh.
And so I did, and I've been doing it ever since. I went back years and years of re-education, of going to continuing education courses and getting certified and developing a body of knowledge in this area. And I certainly took your courses, and I'm so grateful for all the work that you have done.
Oh,
And
you're very kind.
now here we are.
Wow. Um, yeah, I'm a little bit speechless because I'm visualizing that fall. Um, that probably still gives you chills even to talk about it, I would imagine.
Yeah, I've got a pretty
Um,
good sense of humor about it, but it was
okay.
not a fun.
No, I can imagine it's one of those things in hindsight, maybe. There might be some some humor, but honestly, wow, that I think it's so interesting, isn't it? Because so many people that I talk to working in pelvic health have a journey that included their own pelvic health adventures or misadventures. Certainly I know my own obstetric events kind of, led to a career change from sports medicine into pelvic health because you're still quite an active athlete as well, aren't you?
Yes, I am. I'm a runner. I was a collegiate athlete. I was a competitive gymnast. I'm a very active person, so I do have a heart for ortho as well.
Yeah. And I think that's so important, isn't it? That we bring that kind of ortho and neuro mindset to pelvic health because sometimes we can just get very vagina centric
Yeah.
and, or anal centric, I suppose, as well. But, primarily vaginas is what I talk about. And we forget that there is a whole person attached to that. And to bring that kind of musculoskeletal awareness to pelvic health, I think is super important, particularly when we are working with athletes with pelvic health issues.
Yeah, absolutely. You've got to
Yeah,
think entire segments and entire person.
yeah, yeah. So not only are you a renowned pelvic health physio, you are intimate Rose.
Yeah, yes.
How did that all happen?
After, being in the clinic and being in these treatment sessions and listening to what my patients were needing and wanting to empower them more during their home program and as an extension of therapy or when they were not able to attend therapy, I wanted to create products that were bridging the gap quicker and helping them reach their goals faster. And I wanted to create things that were ultimately the most comfortable and easy to use. There were some objects on the market, but none of them were really hitting the mark in terms of comfort, ergonomics, user friendly, geometry on them. And then I wanted to make them really soft and also really bright and cheerful and hopeful. I wanted it to not be like a medical looking object that had
Yes.
stigma attached to it. So our colors are very bright and very cheerful, and it's just what I wanted it to be.
It would seem potentially like a really minor detail to some people, but those dilators spark joy. I mean, they are beautiful to look at, and the colors and just the texture, the feel of them in your hands, I think. Um, I literally this morning spent a half an hour just sitting with a set of dilators and a vulva model, explaining to somebody who'd gone through radiation for her gynae cancer. And we practiced using them on the vulva model. And you could literally just see the fear melting away as she got to touch them and handle them and just kind of build up a little bit of muscle memory so that when she's actually at a point where she's going to be using them herself internally, just that fear factor will have been diminished, I think, significantly compared to those awful white, sterile, plastic, nociceptive devices,
Yeah.
frankly, that so many people are handed. So I just want to congratulate you because I love the shape of them. I love how they feel ergonomically in the hand. And I love as well, kind of again, the attention to detail, not only with the color and the shape, but also, you've gone the extra mile. We've got vibrating ones, we've got, heated ones, and you've even created handles for people who are maybe of a larger size. Just the ergonomic considerations, I think, really put them, I think, above and beyond whatever else is out there. So I just, I wanted to fangirl a little bit about them because I think they're an amazing product. Um, but let's talk a little bit about your experience and your knowledge around a biopsychosocial approach to using dilators because, on the surface, they're very bio. We're using them to stretch or desensitize tissue, or reestablish a proprioceptive relationship between the brain and the nervous system and the pelvis. Is there, from a pelvic pain perspective, is there any evidence to support their use? How do you recommend people have these conversations with patients about using the wands for people with pelvic pain?
The wand specifically or the dilators or
Oh,
both?
either, both.
Okay. Yes. So there's a body of evidence on the dilators for women who have vaginismus, MRKH and AIS, so the
Mm-hmm.
vaginal agenesis classifications, and then also those who have experienced cancer. And one of the things that I wanted to touch on with cancer, and you know this so well, is that breast cancer leads to
Yes.
significant changes in the vulva and the vaginal tissue, and they may have had extra radiation there, they may have had surgery there, or it may just be a byproduct of the chemotherapy and hormone suppression that they are on, and that often totally takes them by surprise. So when we're talking about the cancers, it's the gynecological cancer, the colorectal cancers, and I want to group in the breast cancers with that too.
Mm.
But the body of evidence varies. We've got bodies of evidence from the US and from England and from the UK and all different regions. And so, the studies are not all similar, but that's what I love about them. There's different groups looking at MRKH and AAS differently than we're looking at vaginismus. And so from that, we can look at the different protocols. And then what I always recommend is that we look at the patient in front of us and see what their whole complete medical history is and psychosocial history is, what their schedule looks like. Because when we're looking at protocols, some of the protocols are calling for a 30-minute session, and some of them are calling for 3 10-minute sessions. And so I think at some point the results become very similar as long as there's diligence and there's consistent practice. And so we just encourage our person in front of us to be working with them, if they can, up to 30 minutes or sometimes 2 sets of 30 minutes per day. But as you mentioned, talking about the biopsychosocial approach, there's one particular study. It was a study that looked at having a more comprehensive dialogue with women about what their needs are pertaining to education, in therapy, and from their providers, specifically when they have vaginismus, and working with the dilators. And the topics that came up the most, what they saw come up in these dialogues were that they needed proper education in how to use them. So just like you said, you just spent 30 minutes going over for the first time. And oftentimes, we spend that time and they go home and they practice, and then they come back and they've got 10 more questions.
Absolutely.
Spend another 30 minutes pertaining to education there. So it just really never stops. And then approachability of their provider was a topic that came up with almost every participant in the study. I think the thing that happens in pelvic physios is we are so kind. We have extra time with our patients and we are empathetic. So that makes us the ideal person in the medical care team to be working with patients on their dilator use. And it just makes sense from a body of knowledge, place
Absolutely.
to where we've got profound knowledge of anatomy and also body position changes and mechanics, because sometimes it's that we need to make a body position change. They may need to be doing their dilator training starting in a deep squat instead of just lying on their back in that supine hook lying position.
Yeah.
So that's the body of knowledge on dilators. Wands are a little different. We don't have a real robust body of literature, but we do have some different looks at models that include anything from trigger point release with a needle from a physician to general pain management and all this wonderful new science on therapeutic pain education and how we're speaking to people and how we're framing it, and that they need to be moving their bodies in certain ways and getting blood flow to the area. So when it comes to the wands, I always recommend that we look at it kind of from that orthopedic lens, where this is muscle tissue, these are tendons, there's possible changes in the tissue with pertaining to scar tissue or changes with stenosis from radiation. And then we apply all of that really good pain therapeutic education and working with our counseling teams and our therapy teams. I always like to recommend using a top-down approach cognitively too, where they have like a mantra or a saying that they use for it, whether it's a dilator or a wand, where they're saying this is a tool to help me, and they can place it on their arm or someplace that's not close to the genitals, and be starting their breathing program there to just get their sensory system ready, be priming their body for it, and then they can introduce it at a later point. So that's more anecdotal,
Sure.
combining
Well, experience as well, though. I mean,
Yeah.
that's clinical experience on your part, bringing what you know about working with human beings.
Yeah. It changes daily.
Well, let me contrast that with somebody that I saw a couple of weeks ago who was given one of those dreaded white plastic dilators and told to sit on it for 30 minutes. Well, you see, that's what I was trying not to do. For those of you who are listening, we both kind of grimaced and Amanda covered up her face and shuddered. Can you even imagine? I mean, because I just felt like I was having a little aneurysm as she was telling me. I'm trying to kind of nod, but I have no poker face at all. Yeah, and she's like, and I really don't want to use them, but he says I have to use them, or else have sex 4 times a week. And I'm like, oh, no, it doesn't have to be like that, but to try and talk somebody back from that to really, because, now this is in her head. So to be able to show her the dilators that you've produced and the wands, because actually we ended up starting kind of talking about a wand because it's got that, just something with a nice tapered edge and it's a nice color and she could hold it and just really start just even working on her inner thighs and just really dialing her nervous system back down again. Because I think sometimes, we
Oh, you're on mute, but you're back. Oh no, it's still on mute.
there we go, and I'm back.
Yeah, we're
Not
back.
sure what happened there. The tech gods got a little feisty. The point I was trying to make is that sometimes we assume, or I think sometimes oncologists assume, that you just take these and it's off to the races, with these devices. Whereas we're dealing with people who've been through major trauma, usually if it is a cancer diagnosis and treatment, or, we know at this point that statistically 1 in 3 females and 1 in 4 males will have experienced some sort of sexual assault or trauma. We really have to kind of integrate the nervous system and the brain into our approach when we're using devices like these. It's not just a matter of pop it in and just dissociate from what's happening in around your pelvis. And another kind of issue that came up again, and I'd love your thoughts on this, was that we were having a conversation, this was with another person, but I was using a size 3 last week, so that means I should be on a size 4 this week. And I'm trying to explain kind of, the concept of beginner's mind, and we're just bringing that element of mindfulness. Every session is a new session. And we just start there. Do you find that's a common theme, or, how do you discuss that with people?
Absolutely. It comes up all the time. They want to see a nice, straight, linear progression of goal achievement. And
Yeah.
what I like to remind them is that, first of all, when progressing from one dilator to the next, it is very common to require several weeks in between working with one dilator. And sometimes when we learn a new skill with our coordination system, things can move a little bit faster. And then sometimes when we're experiencing tissue issues or restrictions and things that require a little bit of a softer touch and a little bit more of a longer duration progression, it is common to experience a little bit of a plateau. So, and in fact, when we're looking at progressing through dilators in search of achievement of a goal, it can look like a bit like a stock market where there may be some dips. You may have a stressful day and find that size 3 is not tolerable today. And so today we're going to use size 2 or size 1, and we're going to do what we can do today. And then give yourself some time, give yourself some grace, and you come back and you're able to do size 3 and you're there for a few weeks. And then we go to size 4. And that is just part of being a person. It's the same way with any other body program. Like if you were doing exercises, you might have a day where you're fatigued and you're not able to do the exercises the way you would if you're having a great high energy day.
Fantastic. Yeah, that's a really useful analogy. So if somebody has not had the concept of wands or dilators, as a patient coming to see you, if that's just not even been mentioned to them, how do you introduce this as a topic of conversation? How do you get them excited about using these tools? Because again, they can be quite intimidating in an area that has been traumatized physically as well as the mental trauma that's gone on. Whether, again, primarily through a cancer perspective, but I think even, with people who are dealing with issues like IC or bladder pain or endo, there's such a lot of trauma and fear sometimes held in the pelvis. And then, you're going to see your physio and she's, the patient can often be, you want to put what, where? How do you initiate that conversation?
So It depends on the person. And for some people, that conversation may take place on the second visit. And for some, it may take place on the 22nd visit,
Hmm.
just depending on, where the person is in terms of their learning abilities. And, for example, generally speaking, I want to have done some form of external evaluation and internal evaluation before I'm recommending any product at all. So that means that I have built a trusting therapeutic
Hmm.
relationship with my patient. That may mean that we have relied on ultrasound imaging first to do, a through the belly approach so that they are learning some new coordination skills. Or we've done some mirror work, and they've been practicing at home. And it may mean also that I've just been able to reach a pinky inside and locate some tender points and also do some external manual therapy that has gotten them feeling better, and that they have started to recognize some gains. And then we're going to approach them doing some management at home. So I like all those things to be in place. I like for patients to have demonstrated a good drop and relax of the pelvic floor
Hmm.
on their own before I'm sending them home with the tool, because we need that. That's kind of the cornerstone
Yeah.
of control in order to insert anything into the vaginal canal or the rectum. So, and again, so that they may have demonstrated that during eval, or they may have demonstrated that months in, because it's taken us a lot of different methods and practice to get them to that state. So drop and relax, and then some tolerance of some manual therapy, generally externally and then internally. I will admit, with my patients, we do a lot of internal manual therapy. I do a lot of
Hmm.
very gentle strain counter strain techniques, and they feel a lot better, and they are often chomping at the bit for how to do that at home. How do I replicate what you're doing? And so
Sure.
that's where the wand comes in.
Yeah. Okay, so I canvassed for some questions for, the burning questions that people have about wands
Yeah.
and dilators. Um, do you think that the patient's relationship with their wand and or dilator, is that a lifelong relationship? Or, and I suppose again that might differ for, say, pelvic cancer versus pelvic pain.
Mhm.
Do you feel that's a lifelong relationship, or is it a kind of, a finite start and end? What are your thoughts?
Yes, definitely diagnosis specific. So some people
Hmm.
with cancer may be relying on them just to maintain mobility, especially if they're experiencing lifelong hormone suppression and those kinds of things.
Hmm.
What I've observed, and this may change as we go through time, what I've observed is that people's relationship with their wand is lifelong, because there tends to be either some neuromuscular patterns that creep up during times of stress, or as they go through life. And I will readily admit, I am one of those people that just from my injury, there's certain things that, if it's a stressful time or I've lifted something just wrong,
Sure.
then I'm having to rely on the wand. And so it's there just as a means of self-care, even if it's not every day. It may be just,
Yeah.
oh goodness, we're going through, it's the holidays, it's a very stressful time, we're going to be using the
Yeah.
wand. With the dilators, I see people graduate out from those over
Okay.
time. So, and it may be that they, again, if they experience a stressful thing, they may just re-practice, kind of
Mm.
organize their musculoskeletal control system. But I see people graduating out and away from those over various periods of time, 6 months, a year, 2 years, that kind of thing. It's not always immediate, but they get to a place where they no longer need them. But the wand tends
Yeah.
to be a lifelong companion.
It's reassuring just to know that you have that, kind of in your bathroom cabinet or your sock drawer, wherever you keep it, that that there's something that if you're having a flare, there's something that you can do. And I think as well, though, similarly for people who've had radiation as part of their pelvic cancer, we know that radiation is that gift that keeps on giving as well. So I think it can be quite useful to have that as a maintenance program too, or to switch to using the wand and just, as a little self-care routine. Um, okay, the next question that came up, there were three questions. So that's the first one. The second one is, how soon after radiation treatment, do you recommend using the dilators during radiation, after radiation ends? Because I know different oncologists have very different thoughts on this, and it varies
Yeah.
wildly.
You
What are
got
your
it,
thoughts?
100%. I mean, coast to coast, I've seen totally different protocols, and I'm always watching for what different surgeons and oncologists and radiation specialists are doing. So as a physical therapist, I always have to defer to the physician. And so following their protocol, and it's really interesting. I have seen physicians recommend them within 3 days, and
Yeah.
they are wanting people to get started right away. And then I've seen them wait till 6 weeks, and then I've seen them wait till 12 weeks. From a purely observational standpoint on my little place as a pelvic physio, I think that as long as they're being safe with it and using plenty of lubrication, and when I say plenty, I mean a teaspoon on the dilator and then loading a suspension syringe
Yes.
full of lubricant and shooting that up into the vaginal walls to totally coat the vaginal walls. And then working with the smallest dilator just to work on the sensory system. I think that people can be very successful, and then their body is trained from an earlier stage.
Yeah.
Kind of like these protocols, like when you look at the knee, people would have like a knee replacement, and long time ago it was don't move, stay in bed. Now they're like,
Yeah.
get up, I want you walking 200 feet right away,
I know.
90 degrees of flexion immediately.
Yeah.
So yeah, it is
I
specific.
it is one of those kind of how long is a piece of string questions. But so generally, because we either come across oncologists that have very firm ideas about when, and again, as you said, it could be during radiation, it could be 2 days after your last treatment, it could be 6 weeks after your last treatment. But sometimes what they will say is ask your physio, and they will toss the ball back over here. So as far as you're concerned, just very gentle, loads of lube, gentle tissue separation, keep it sub-threat, non-nociceptive, and proceed cautiously. Is that
Yes,
a
yep. And I think if we frame it, if we in our heads as physios frame that stage as mobilization, so even if they can tolerate, like the smallest dilator is the size of the pinky, and they could be tolerating size 3, even if we start size of the pinky and just be doing gentle sweeps and be
yes?
working on the sensory system and just thinking purely on mobilizing tissue, I perceive that there's going to be better results when it is time to do the actual, I hate to even throw the word out there, stretch of like making sure that they are able to maintain that pliability to
Sure.
tolerate the speculum or their partner.
Yeah.
So mobilization.
So early mobilization. Yeah, because I mean, my fear is always, with sometimes, when I hear like 3 months or even 6 months after radiation, it's like, oh, have we missed the boat for
Right,
optimal, you know? I
right.
worry about that a little bit.
I do too.
Yeah,
Yes.
yeah, okay. So the final question that came up was rectal dilators.
Mhm.
Is there any evidence to support their use? Or how do you recommend, is there any sort of protocol that you recommend with it? Because, the anorectal canal is a different beast than the vagina.
It is, yeah, different muscles behaving in different manners. We have
Mm,
circular smooth muscle. So in terms of protocols, there at this moment, I have not yet seen it published in the literature. So I need, certainly I do little sweeps as often as I can, and I have not yet seen one. I do think about what we're doing with the sensory nervous system and what the evidence is for the vaginal dilators and the vaginal tissue, and I do try to apply those. So when we're thinking about training for differences of training for expulsion of having a bowel movement. So patients with
yeah,
outlet dysfunction and constipation are certainly going to have a different protocol than those who may have had the radiation to that tissue and we're doing mobilization. So from there, the person with the outlet dysfunction, I
mm,
liken the rectal dilator to balloon expulsion training. So
yes,
where we're teaching the drop and relax, we're inserting it and then having them practice expelling it. And what I've loved is that, the profound light that goes off when they first expel the balloon is one of my favorites.
yes,
It sounds so weird, but it's like those patients are so miserable that once
I
they're
know.
finally able to expel a balloon, it is such a light bulb moment. Those are some of my favorite cases. So when they're able to replicate that at home, so wipe it off and then put it in and do it again, and they're able to get
Yeah,
rest they tend to get to that stage where they're able to have a bowel movement much sooner. So I liken it to balloon expulsion training in that regard. And then on the stenosis radiation regard, it's the very gentle mobilization techniques. I recommend working with it 10 minutes 3 times a day or up to 15 minutes. With the vaginal dilators, we could certainly go 30 minutes. With the anal sphincter, a concern that I have is just overexertion on the anal sphincter itself. And so, and I have no data. I want to be very honest, like there's just no data about what kind of timeline or anything. But for me, when I'm thinking about the person on the table, I'm thinking 15 minutes max of having something in there and that they're working with is probably a good thing. And always having them monitor themselves, because people can have a vagal experience when they're working with their rectum and their anus.
Concentrating so hard.
And sometimes, and even just sometimes that nervous system can get tripped up by feeling something going in when they are years and years and years and years trained to only have something coming out. So for that reason, I say start small, couple minutes here and there, building up your tolerance. So
lovely. It's lovely. Yeah, again, when you get those light bulb moments, because then you can literally just send the person home with the dilators and say, okay, this is what you need to work on. You know what to do, because this hour and a half, whatever they have with us, is such a small portion of their week. And if we're going to really do brain training, it's just little and often with that novel sensory input, isn't it?
Absolutely.
Do you recommend daily use?
Yeah. And with the understanding that there may be a day in there where they just rest, and that when schedules get busy, they give themselves grace, but daily.
Because I mean, what we're really talking about, yes, we are looking at enhancing tissue mobility, but we're really training the brain and the nervous system more than anything, aren't we?
Yes.
So I think those regular inputs are important. And my other fear is, if we tell people to do it 3 times a week, it's like, oh, I can't do it today, I'll get back to it tomorrow. And then one day becomes 3, becomes 5. Whereas if they know they have to do it every day, they, it tends to be a little bit more consistent. And that's when you're going to get the results.
Absolutely.
Are there any caveats or red flags for either wand or dilator use that you would like clinicians to be more aware of?
So I know the pain scale is so controversial and that a lot of clinicians aren't even bothering with it, but I like to frame that we don't want people, especially at home and especially under their own pressure systems, to be experiencing, if 0 is nothing and 10's the emergency room, anything beyond a 4 while they're working with their tool. We want to remind them that change is uncomfortable. So you're going to be uncomfortable for a while until you get to that point where you're craving the wand and the release that you get with the wand. But that that 2 to 4 region, we don't want to go beyond that. And it's specific to the person. And so along those lines, I remind people about tomato touch, which is whether you're using a wand or a dilator or their own hand, we're never pushing any harder than when we would use to check a tomato for ripeness.
Oh, I love that.
Yes. If you're going to check, you're going to make some salad or some salsa and you're giving it a little input, you're giving it a little squeeze there, you're checking it, but you're not squishing your tomato. So we're using the same principle with the wand and the dilator, and they can get a sense. And for some people, then they can get a little bit heavier handed once they get the sense. But, as clinicians, we have years, most of us, of manual therapy training and skills. So when we are touching tissue, we approach it very gently. Our patient, they're not physiotherapists, so they don't know how to approach their tissue. And so sometimes they think, well, if some is good, a lot is better.
More must be better.
That's right. I'm just going to grind this out. And we know that they can have rebound pain, they can have guarding pain, they can start to have negative associations with their tools, and we don't want any of that. So minding the pain scale and tomato touch.
And don't forget to breathe.
And breathe.
Basic but important.
Yeah.
I just feel like this is such an important conversation that we've had, so many really useful takeaways, because I think sometimes, particularly if you're starting out in pelvic health, using things like wands and dilators can be kind of scary as a clinician, never mind as a patient. I feel like you've really demystified a lot of it today. So thank you so much for all that. Where can people find out more about your products, about you, and all the things that you're doing?
Yes. So on our website, intimaterose.com, got hundreds of different videos and guides and how-tos there, and everything, all the education there is free. And then on Instagram, we do a lot of fun content and easy to digest videos on the tools, and that's Intimate Rose. And then also on Instagram, I am at A Olson DPT.
Brilliant. Amanda, thank you so much for your time, for your knowledge, and for all that you do in pelvic health. And hopefully our paths will cross in real life soon, and I can thank you in person. But until then, gratitude from everyone who's listening, I'm sure. And for all of you who are listening, thank you so much for being here. And I will see you all in the next episode. And until then, celebrate Muliebrity.